ones, and then we're over to you guys. Okay.
Welcome. So I'm Vibeke Strand. I'm an adjunct clinical professor in the Division of Immunology at Stanford University. I also work as a biopharmaceutical consultant, which I've done since 1991, and I help with both regulatory strategy and clinical trial design for new products in rheumatology. I'm also very pleased to introduce Peter Taylor. And Professor Peter Taylor studied clinical medicine at the University of Oxford and was awarded a PhD degree from the University of London for studies on the pathogenesis of arthritis. In October 2011, he was appointed the Norman Collison Chair of Musculoskeletal Sciences at the University of Oxford and is a fellow of St. Peter's College, Oxford. He's the head of clinical sciences at the Martir Research Center within the Nuffield Department of Orthopedics, Rheumatology, and Musculoskeletal Sciences. He has special clinical interests in novel therapies, rheumatoid and early arthritis, and his research experience is in the mechanisms sustaining inflammation and clinical trials of new therapies with the development of novel outcome measurements for application and assessment of response to therapy. He and I both share a great interest in patient-reported outcomes, which is what we are going to be speaking with you today. And I'll just share quickly our disclosures. So you will be on mute for the duration of the meeting. Questions can be submitted at any time through the Q&A function. And while I'm showing the slides, Dr. Taylor will be keeping an outlook on the Q&A. If you have any questions or experiencing any technical difficulties, please also use the Q&A box. So we're going to start and essentially discuss the effects of JAK inhibitors on patient-reported outcomes, and particularly also pain, which is a very central aspect of the impact of disease. So what we know is that there's some discordance in the way both patients and physicians, healthcare providers really agree or understand how the impact of disease occurs. And here we're looking at how patients and physicians actually define flare. And you could see in the blue, the healthcare providers' definitions of flare, and in the red, the patients. There is an agreement about pain and function. So that seems to be quite central to both perspectives. But if you notice, the patients aren't really looking at joint counts as much as they're thinking about participation, stiffness, self-management, fatigue, systemic features, sleep, and emotional distress. And this is also true when we see the discordance between a patient global assessment of disease activity and oftentimes a physician assessment of disease activity. So understanding patients' needs, the survey was done in 2015, published in 2015, and this was asking patients online the definition of a good day survey. And this was about 2,000 survey respondents from 5 European countries, the US and Canada. And they're asking about the effect of RA on their lives and emotional well-being. 58% said a good day would be a day free of fatigue when they had energy. 57% a day free of pain. You can see the other aspects as well. And similarly, a follow-up was to ask patients about their targeted approach to disease management. This time it was again about 2,000 survey respondents with rheumatoid arthritis from 6 countries. And 92% said having a good day would be a great goal as a target of therapy. 88% that discussing my treatment with my healthcare provider is important. And then you could see the other numbers as setting goals and so on. But what was very interesting is in this Getting to Your Destination Fast survey, almost none of the patients said they'd heard of treat to target. And yet they were talking about making personal treatment targets for their RA, and that this would be their best goal. In other words, getting to their destination fast. And so this is an important lesson that essentially should move forward, but think about asking and setting a goal every time a new therapy is added or switched, and asking about that at every visit. It takes just a few minutes, but it's a great way to status how your patient and you are progressing on the jointly agreed to goal.
Vibeke, thank you very much indeed. So one of the things, of course, that you've highlighted in the real adoption of treat to target in people's thinking over the last decade or so is that it's been drummed into us all again and again that we should aim where possible to achieve a remission and adapt and modify treatment, titrate treatment where necessary, or switch to alternative mechanisms of action in order to achieve that particular goal. And where remission is not achievable, then a secondary goal might be low disease activity. But it does beg a question, I think, that whilst there is really compelling evidence that this approach to management allows for best outcomes for patients at a cohort level, you and I and all our viewers, of course, see individuals. We might think we see cohorts in the queue outside the clinic, but actually the reality is we sit there with an individual. And what you've been highlighting really is some of the aspects of life that matter to the individual. And so here now we're focusing on the issue of pain. And once again, at a cohort level, in fact, a large number of patients, over 2/3, rate pain as being their first and most important priority over other disease symptoms. And there are many different reasons for this. One is because it can be associated with psychological distress, of course, but it impairs physical and social functioning. We know there are strong relationships between physical functioning, which can be assessed with the JAK questionnaire, and also social functioning and pain. And of course, pain can decrease quality of life overall, but not only that, it adds to the burden of healthcare utilization. So this is a big issue. Now, I rather like this diagram because it takes ancient physicians such as me, but anybody who has perhaps a more traditional education in medicine will remember the generic features of inflammation. And in fact, these are not new. They were actually defined by the Romans, and perhaps we can see the first Roman pop up on the left-hand side. And in fact, he described the first 4 of those features. And so those of you with a classical education might remember calor, rubor, tumor, and dolor. And then a 5th feature, the poor chap who's lost his function on the right, you can see was defined by Galenus. So there's nothing new about this really very nice observational description of the generic features of inflammation. But what we do have to do is ask ourselves a question, and particularly if we think about pain, which is such a dominant issue for the patients from a subjective point of view. And the question is this, that if we try to treat to target, and treating to target is all about, at least if you look at a disease activity target, it's predominantly about trying to suppress inflammation optimally over time. And so really just to come on to the question that will pop up below at the screen next, is this, that if we aim to treat to target just by modifying treatment according to the inflammatory burden of arthritis as measured by composite scores of disease activity, can we adequately manage pain? And of course, if pain is entirely due to inflammation, that might be the case. But as we move on, we might see that there are other issues. So let's take a look at these now. So inflammation, as I've already mentioned, is associated with pain. But if we come on to some of the other features, nociception at a peripheral level causes pain locally. We also know that inflammation can involve a systemic inflammatory response, and of course that's reflected in the acute phase markers. And local inflammation causes acute pain, which can be well localized in the somatosensory cortex, but that may result in lower physical activity. That in turn may result in loss of function, and loss of function may exacerbate central sensitization together with an ongoing nociceptive input, both from the periphery and in the context of systemic inflammation. And the consequence of all this is that persistent pain may result, and the character of the pain may change, as many of you will have observed in your patients over time. So pain in the patient in established disease is often much more poorly localized and has a character of mechanical allodynia in many respects. So we can ask ourselves the question, what do disease-modifying anti-rheumatic drugs do? And of course, we know that they do many things. One of them is to suppress the local and systemic inflammatory burden. Arguably and debatably, there may be some effect of DMARDs of any sort on central sensitization, but I think that's a much more contentious issue. And if we move onwards now, so you can see there are a number of levels at which these drugs may work. But if we were to move onwards and think about how we measure pain, well, actually, our ability to measure pain is really rather paltry. So what is done in clinical trials and is very well validated is to take a 10 centimeter scale and either use a numerical rating scale or a 100 millimeter visual analog scale. And we simply ask our patients to make a mark at the level that best reflects their pain in the preceding number of days, which we define in the question. But if we think about the nomenclature that we all use for pain, whatever language you might speak, in nearly all languages that I'm aware of, there are numerous adjectives that might describe pain. And I've just illustrated a few of them here. Stinging or pounding. I remember when we were learning our surgical trade that we talked about colicky pain as opposed to sharp pain or dull pain or pinching pain. And so really the experiential aspect of pain is very complex, and the emotional interpretation of pain is complex. And yet we try and capture this complexity with this really rather paltry scale. And just to make matters worse, when we ask patients how much pain they're experiencing, this doesn't even tell us which bit of their anatomy is hurting or where the pain's coming from. So although this is a very well validated tool, I think the serious point here is that it's a really very blunt instrument. So moving onwards on this whole issue of pain and experiential pain, there's this issue of local nociception and acute pain, but using something called a pain detect questionnaire, which was actually developed to look at spinal pain. But when it's been applied to patients with different kinds of inflammatory arthritis, what emerges is that, in fact, it's said to detect more of a neuropathic character pain. And if you look in rheumatoid arthritis, psoriatic arthritis, or in the spondyloarthritis, there's quite a substantial proportion of patients who still report significant levels of pain, even when the inflammatory component of their disease appears to be well treated. And I think this raises many real questions about the origin of the pain they're reporting, what is the underlying neurobiology of the pain, and can we treat it adequately simply by treating to target? And perhaps that introduces the whole concept of some further issues that patients complain about, Vibeke.
Yes, so I think fatigue is one of the other prominent complaints and impacts of disease. And we see that from this nice model that was developed during OMERACT work, that fatigue is multidimensional. It has many different aspects, and it is due to many different things. And patients often say that you don't experience fatigue until you've developed an inflammatory arthritis. And then it is a very different type of complete and very total feeling of fatigue. And you can see it has cognitive and behavioral aspects to it, very much personal aspects. And of course, it is influenced by the underlying inflammatory disease. So we see that the unmet needs in rheumatoid arthritis are linked, basically fatigue and pain. And then we talk about depression, mood disturbances, emotional aspects. And we understand that somewhere between 40% of patients who have severe fatigue and 61% of patients who experience poor sleep. And yet there's also the restrictions in social participation, of course, and emotional participation, and the ability to work or participate in activities that are desired. So if we move on to the patient-reported outcome measurements that we've had in RA trials, and particularly with the JAK inhibitors, we see, of course, that the triad of patient global assessment, pain, and physical function, which are included in the ACR response criterion, are a set of 3 PROs that we see across all trials. And then, of course, there's also health-related quality of life. And we have 2 measures of that, the SF-36, which includes a physical component and mental component score, as well as the 8 domain scores. And we'll drill down to the domain scores because I'm not sure what a physical component score means or a mental component score means, as they are equations based on all 8 domains, but the PCS weights 5, the 4 physical and the vitality domain positively, and the remaining 3 domains negatively, yet the MCS weights the 4 mental domains positively and the 4 physical ones negatively. So it's really not a concept that I think we can understand, and nor are they symmetrical or opposed. And then, of course, there's the EQ5D, and both of these instruments do give you health utility measures, which are useful for economic and clinical analyses. And we talked about fatigue. The facet fatigue has been well validated in RA. And again, all of these, we can define responders. And finally, there's also the medical outcomes survey sleep, which has been utilized, but we do not have measures of clinically meaningful improvement yet. So we see the spectrum of improvements in these patient-reported outcomes as defined by OMERACT. We have the minimum clinically important difference, which is the amount that patients just perceive as improvement or deterioration. And in fact, they will report deterioration sooner than they will report improvement. And then we have moderate and substantial improvements, which are often applied to pain, 30% and greater or 50% and greater relief of pain, which I think is quite important. But patients tell us that what they really want is no pain. And so it's rather of interest how to look at different levels of pain relief. Finally, there's a patient acceptable symptom state, which is defined by a group of patients with the disease, stating which symptoms they could actually live with if they'd been relieved at least to one extent. And that's a very variable definition, very much dependent on the group of patients. And then finally, we now have patients who can actually report scores that meet or exceed age and sex match normative scores. When we have those, we have normative scores for the facet fatigue, for the HAQ. We have normative scores for the SF-36, which we can be defined by age and sex match and country match norms, although they're quite similar across countries. So when we look at the tofacitinib, baricitinib, and upadacitinib patient-reported outcomes that were used in the trials, we see that we have the patient global with an MCID of greater than or equal to 10 if it's a VAS score and same for pain. We have the MCID for HAQ of minus 0.22 points and facet 4 points. For the SF-36 PCS and MCS, it's 2.5, but provided one or the other is statistically significant, and almost always the PCS is, then we can look at the individual domain scores, which I'll come back to, where the MCID is 5. So we look at the percentage of patients who report improvements that meet or exceed MCID definitions, typically at week 12. And then we also look at number needed to treat based on these percentages, which is 1 over the difference in response rates between active therapy and placebo. And then I'm going to introduce you to the spidergrams, which actually illustrate the changes across the 8 SF36 domain scores, compared with age and matched normative values, as well as, of course, baseline scores.
Thank you, Vibeke. And of course, one of the things that you've just pointed out really is the recognition, both by regulators as well as input from patients themselves and from clinical trialists, of the importance of these subjective measures. And looking at these JAK inhib studies, how many subjective measures are captured, whereas you and I both remember some of the historical trials in the early days of TNF blockade, when only 2 or 3 patient-reported outcomes were captured. So this has really been an evolution in thinking where not only have we seen potentially more and more efficacious outcomes with respect to composite scores of disease activity, but the real willingness to capture much more and more of the experiential aspect of the burden of disease. But what we're looking at now in the graph in front of us is something a little bit naughty that you're not really supposed to do, but I make no apology for it, because what I'm showing here is 4 completely independent studies, and I do want to emphasize that they're independent and they're being indirectly compared. So in other words, each of the 4 studies that are separated by the vertical red bars are in different populations, so one has to be very cautious about comparisons. But the reason for showing them is that each of these is a JAK inhibitor study. In Europe, we now have 4 JAK inhibitors approved in the clinic. And each one was a study in methotrexate inadequate responders, where a JAK inhibitor together with methotrexate was compared to adalimumab together with methotrexate. And I think what we can conclude from this, whilst being cautious about any comparisons, is that the JAK inhibitors themselves are showing at least a similar efficacy, if not somewhat better efficacy than that of anti-TNF plus methotrexate. And really that's the message here. So having demonstrated that on the basis of composite scores of disease activity after 6 months of treatment exposure, that we're seeing a highly efficacious treatment right across the class of JAK inhibitors, what we then need to go on and do, and we'll discuss subsequently, Vibeke, I think, is the degree to which these new oral agents can actually improve the patient's experience based on measures with PROs.
So we're going to start with the DMARTIR population, and we're looking at phase 3 trials with baricitinib, tofacitinib, upadacitinib. Of course, you see RA build and then RA beam with baricitinib against adalimumab, which we just looked at. And tofacitinib, there was sync and scan and solo, and then there was standard versus adalimumab. And finally, with upadacitinib, next monotherapy and compare versus adalimumab. So this is the oral solo study, and this is just the early improvement that was reported 2.5 to 3 days using an IVRS system, a voice recognition system, for patients to report global and pain. And we could see that this rapid improvement was actually sustained over time. And you could see here up to 6 months with the primary endpoint at week 12, where the placebo patients were crossed over and had similar improvements. So the early improvements do continue.
Right, and looking across some of these programs in a very large phase 3 trial set, this is with tofacitinib, which is predominantly a JAK1/3 inhibitor, but has some pan-JAK capability, that you can see that for a monotherapy with oral solo on the left, but also in combination in the other 3 studies, that the JAK inhibitor in either the red or the sort of darker hatched red color is differentiating from the comparator. What's interesting in oral standard is that there's an impression that at least numerically the JAK inhibitor does as well, if not better, than the anti-TNF comparator. That particular study was not powered as a head-to-head for statistical analysis of comparison, and we'll look at some other studies that will do that later. But again, we're getting a feel that for this first JAK inhib to come to clinic, that there's a very deep improvement across all these different populations at different stages of evolution of rheumatoid arthritis.
Yes, and I think that the early onset of benefit is something that is very helpful too, because patients tend to be more adherent.
Right, absolutely. And this, of course, gives the patient real confidence and helps build the patient-physician relationship. Now, in Europe, we've had a JAK1 preferential inhibitor approved recently called filgotinib. And this is a rather busy table looking at the phase 3 trial results, but I'm just going to highlight some key bits. So perhaps, Vibeke, if you could just click the button and that will highlight for us some of the key findings. So here in the Finch 1 study, this was a head-to-head comparison of filgotinib at one of 2 doses with background methotrexate versus adalimumab plus background methotrexate. And what you can see is by 1 year of treatment exposure that with the higher dose of filgotinib, there was a numerically greater improvement in pain relief than was the case with adalimumab. And on the right-hand side, you can see highlighted for Finch 2, which was in a biologic inadequate responder population, that the higher dose of filgotinib gives about a quarter of the patients achieving a really very, very high degree of response with 10 millimeters or less of residual pain. So Vibeke, you pointed out earlier that when we look at these different degrees of magnitude of response, that really ultimately what we want to aim for is no pain at all. And here we're looking at a close approximation to that. And on the left-hand side in the Finch 3 study, which was in a methotrexate naive population, again, you can see in that study that about 40% or so of the patients on the higher dose of filgotinib achieve this remarkable degree of pain relief after 52 weeks. You'll also see there's a methotrexate comparator, and I think all the viewers will remember that the EULAR recommendations for rheumatoid management and the ACR recommendations are that we should use methotrexate first. And of course, we can get some very good results if we use methotrexate very early on after the presentation of rheumatoid. But again, you made this point, Vibeke, earlier, that the JAK inhibitors also have this advantage of the rapidity of response, where, of course, methotrexate, we tend to have to wait longer. So these were interesting results for this drug. And there's another JAK1 inhibitor that's available on a more global basis now, upadacitinib. It's relatively selective for JAK1. It does have some influence on the JAK enzymes as well. And here, again, there was a huge phase 3 program, and you can see the different populations, a monotherapy study. Select Beyond is in a biologic inhibitor refractory population. But the Select Compare study, which I've highlighted on the top left, you can see in the yellow upadacitinib, which is the JAK1 inhibitor. It differentiates nicely from placebo in gray, but it also differentiates numerically and at some points with statistical significance from the maroon color adalimumab plus methotrexate comparison. So if we move on now, this is the RA Beam study, and this is a study that I was responsible for. And on the left-hand side, we're looking at the tender joint count, which could be said to be a measure of elicited pain. And on the right-hand side, we're looking at the experiential or subjective measure of pain based on the 100 millimeter visual analog scale. And just as you were saying earlier about tofacitinib, Vibeke, we see similarly that the rapidity of onset of pain relief is quite remarkable, particularly for the subjective improvement in pain. We can see that both active treatments, the adalimumab and the baricitinib, differentiate nicely from placebo in the gray. After 24 weeks, of course, the placebo patients were advanced onto baricitinib, so there was no longer any placebo comparator. But what was also interesting is that the statistical significance between baricitinib and adalimumab occurred early, and that was maintained throughout the 52 weeks of drug exposure. But what we're looking at here is the mean improvement in pain, and later on we'll have a look at some of the detail about the variability within that mean group. So that just emphasizes the rapidity of onset again.
So I'm going to move on now to health-related quality of life, the SF-36. And we're looking at the beginning of a spidergram with the domains, starting with physical function at 12 o'clock, role physical, bodily pain, and general health perceptions. Those are considered the physical domains. Vitality at 6 o'clock, social functioning, role emotional, and mental health are considered the mental domains. And you could see that the scores generally range from 0 to 90. MCID would be half of a grid line, so each grid line is at 10. Here we're seeing now the baseline scores of the entire population in oral sync. And then in the outer parallelogram, we're seeing essentially the age and gender matched US norms for this particular protocol. Here now is the improvement reported by the placebo patients, generally small and less than MCID. And then the larger improvement with the 5 milligram BID, statistically significant in 7 domains. And further with the 10 BID, which is statistically significant across all 8 domains. And then just looking at the percentage of patients who report improvements that meet or exceed MCID. You can see it generally ranges between about 54 and 74%, which is a large majority. And these lead to number needed to treat versus placebo of somewhere between 3.7 and 8.3. And what we understand is that number needed to treat of 10 or less are considered to be both clinically and economically meaningful. Now we can look at upadacitinib again with a spidergram. Here now, this protocol population had a larger baseline scores. They were a little earlier in their disease process. Here's the improvement now with placebo and the improvement with upadacitinib 15 milligrams, again, statistically significant in 7 of 8 domains, and slightly exceeded by the 30 milligram dose, which is statistically significant in 6 domains. And here now are the percentage of reporting scores greater than or equal to normative values. At baseline, we might expect they're relatively few, somewhere between 1 and 12%, unless we look at the MCS score, which, as we understand, our RA patients tend to be a little bit more robust, and they tend to report MCS scores that are higher than the PCS scores. But now if we look at 12 weeks, look at the percentage of patients who now report scores that actually meet or exceed normative values, somewhere between about 15 and 30%, and then for the MCS scores up to 50%. Here's baricitinib again in the RA beam against adalimumab for the FACIT score. And similar to what you saw with pain, you can see also that it exceeds adalimumab at weeks 4 all the way through to weeks 24. And here's tofacitinib in the standard, again, both doses of tofa against adalimumab in the blue, and again, statistically significant differences with number needed to treat that range between 4.1 and 4.9 with tofa and 5.6 with adalimumab. Here's upadacitinib spidergram with compare. And this group had been treated considerably, much lower baseline scores, yet large placebo responses, which are exceeded again by adalimumab, and then by upadacitinib 15, which is actually statistically significant versus placebo across all domains, and versus adalimumab across 5 domains. And here, percentage reporting normative scores at baseline. You see that the WIS, which is the work instability score of less than 10, are those patients who are not worried about losing their job. And so that's somewhere between about 23 and 28% at baseline. You see, again, low scores across HAC and FACIT and SF-36, and similar scores in MCS. But now look at the improvements at baseline at week 12. And now only 49 and 51% of patients are not worried about losing their job, compared to 34% with placebo, and similar large improvements showing that patients can actually feel and function normally as if they don't have rheumatoid arthritis. If we move on to a more heavily treated population, we're looking at the bio-DMARTIR population. We have RA Beacon and Oral Step, Select Beyond, and Select Choice. Here now is RA Beacon with baricitinib. And you'll see that the baseline scores are lower, as we might expect, because this population has been more heavily treated. And the placebo responses are quite low, as we might expect in a bio-DMART-IR population. Yet there's large improvements with baricitinib 2 milligrams and baricitinib 4 milligrams, slightly better than the two, but a nice illustration about how both doses are quite responsive, and we see statistical improvements. And then if we look at the percentage of patients who report improvements that are clinically meaningful across all the domains, you see that that's statistically significant with baricitinib, except for role emotional and mental health, which tend to have larger scores at baseline. But we also see that the number needed to treat across all of the domains generally are around 10, with few exceptions. Here's oral step, again in a bio-DMART-IR population. Again, we see very little improvement with placebo. Large improvements with tofacitinib 5 and 10 milligrams. And what we've learned actually is that in the bio-DMART-IR population, we start with lower baseline scores, but we do have similar improvements in magnitude to the ones in the DMART-IR population. Although overall, the final scores are generally not as high. And the other point is illustrating with the spidograms, you're showing positive improvements. So patients can actually see the magnitude of improvement. Here we're seeing the patients who are reporting clinically meaningful improvements across patient global and pain and HAC, FACIT, PCS and MCS scores, all statistically significant. Look how similar the numbers are. And the number needed to treat ranges somewhere between 3.3 and 8 to 10.6 with tofacitinib. Finally, here's upadacitinib in Select Beyond. We see slightly larger placebo improvements here, but nicely exceeded by upadacitinib 15. And in this protocol, the upadacitinib 30 milligram dose also behaved somewhat more positively than the lower dose, with statistical improvements. Here now looking at a bio-DMART-IR population, very few report normative scores at baseline, as we might expect, but you can see that the MCS scores are still generally larger. But look at these large improvements just at 12 weeks, somewhere between 55 and 60% of patients now report normative scores, which is really quite nice to see in a rather heavily treated RA population.
Thank you, Vibeke. And I think your way of showing this data with the spidograms, which was your initiative, is a really brilliant way of beautifully illustrating improvement over time, but also across all these different health domains. It's so visual and really very helpful. But we're going to come back now to the issue of pain, and the viewers may remember that I mentioned earlier on that in the RA Beam study, where we looked at the mean improvement in pain and compared the placebo plus methotrexate, adalimumab plus methotrexate, and baricitinib plus methotrexate, that the two really striking features were how baricitinib was very rapid in its onset of action, but also how it differentiated even from adalimumab, and that was maintained over time. And so that spurred us on to look in more detail, really, to try and understand the spread of data and spread of improvement. And what you can see on the left-hand side is the absolute pain improvement and the proportion of patients who achieved an improvement of 20 millimeters or less out of a 100 millimeter scale. And it was nearly half of the patients receiving 4 milligrams of baricitinib, just over a third of the patients on adalimumab, but even about 1 in 5 to 1 in 4 of the patients on placebo. So, of course, we do expect and often see some degree of placebo response, particularly in some of these subjective measures. Looking now towards the right-hand side of these histograms, we're looking at the percentage of pain improvement from baseline. And neurologists who've taken an interest in pain have defined an improvement of 50% or more as a substantial improvement, as Vibeke told us earlier when talking about PROs in general. And in fact, we were so impressed by the results for both active treatments in this study that we also looked at a data cut for those patients achieving a 70% or greater improvement. And you can see that over a third of the patients receiving 4 milligrams of baricitinib achieved that. So what this suggests is, what of course we've known for a long time, is that targeted therapies and anti-TNFs are very effective at relieving inflammation, and indeed they're very effective in terms of pain relief. But it would appear that JAK inhibition, and in this particular case JAK1/2 inhibition, was especially efficacious with respect to experiential pain. So if we move on now to look at the kinetics of response in more detail, we've both pointed out that looking across the JAK inhib studies, that a very obvious recurring feature is the rapidity of response in terms of the subjective features of disease. And as Vibeke rightly said, this gives the patient confidence, it probably encourages adherence, and certainly helps with the rapport and trust between prescribing physician and the patient receiving the treatment. So we looked at the median time to achieve a substantial improvement in pain, which is illustrated on the left-hand side. And we were interested to see that, in fact, the patients who received baricitinib achieved this in half the time it took with anti-TNF. Now, of course, I'm sure everybody will realize that JAK inhibitors are multi-cytokine inhibitors, and perhaps that in part is the explanation for this, whereas, of course, a TNF inhibitor directly inhibits a single cytokine, although it will have downstream effects on many others. And on the right-hand side, you can see similarly for those patients with a really tremendous 70% or greater improvement in pain, that it was achieved in 12 weeks, the median time for baricitinib, as compared with 20 weeks for adalimumab. So moving on now to think about this in more detail. So I've just mentioned that JAK inhibitors are multi-cytokine inhibitors. The particular spectrum of JAK inhibition and selectivity may make some difference in the spectrum of cytokines that are predominantly inhibited, but even then this is very complex because of downstream effects on other cytokines. So we asked the question, could it just be that baricitinib was apparently having a greater effect on pain than anti-TNF, simply because it's a multi-cytokine inhibitor, and could it be having a greater anti-inflammatory effect? So we undertook something called a multiple mediation analysis, which is a mathematical analysis illustrated on the left, where we looked to see whether the proportion of observed change in pain could be accounted for by surrogates of inflammation. And we had available 3 surrogates of inflammation: the CRP, the ESR, and the swollen joint count. And based on this mathematical modeling, if you now cast your eyes over to the right to the histogram, you can see that what we found actually is that anti-TNF and baricitinib have a very similar proportional effect on the surrogates of inflammation. And if you look at what we called the direct effect, in other words, the effect on pain itself that we couldn't explain based on the observed influence on the surrogates of inflammation, it was quite considerably more for the JAK inhibitor than it was for anti-TNF. Now, I don't know exactly what this means at the moment, but it generates a hypothesis. And the hypothesis would be that maybe baricitinib in particular, and perhaps JAK inhibition in general, has an effect on non-inflammatory pain as well as on inflammatory pain. And to investigate this a little bit further, we looked at the patients on the left-hand side here, where you can see we're looking at patients either in remission or those who've achieved low disease activity. Now, of course, by a treat-to-target paradigm, if you've achieved remission, it means you should have achieved the best achievable result. But what we observed was that the magnitude of effect on pain relief was greater for baricitinib than it was for adalimumab. And the same was true for those patients achieving either remission or low disease activity. And in that particular case, it was statistically significantly different from anti-TNF. And there are similar observations around function. And already we've mentioned that function and pain are very strongly associated.
So I hope in how we've reviewed this that you understand better the importance of the patient population. We definitely know that they're more responsive if they're earlier in their disease process and have been less, shall we say, treated. We also know that methotrexate IR patients have generally experienced great improvement with this, their first DMARD, after they've already experienced a significant impact of disease. And we've seen that the HAC will now plummet and their pain levels will change and their fatigue levels will go down. And they often then will experience similar types of benefit with the JAK inhibitors. We now also recognize that our patients are much more active. Most of them are working within or outside the home. They have high expectations for control of their disease. They want to feel and function normally. And I hope that this data has convinced you that it actually can be attainable. And furthermore, the JAKs offer great convenience. They're oral and thus much easier for those who travel.
Vibeke, I wonder if I could stop you before we think about some of these summary points, because we've had a very good question from one of our audience. And I'd like to thank Edgar Stemier for his question, or Stemler rather, for this question. And he thanks us for the talks and asks whether the multi-cytokine related concept of JAK inhibition might not only serve as a rationale or explanation for the better improvement of inflammation-driven pain, but could it also be an explanation for the alleviation of non-inflammation driven pain, for example, neuropathic pain? And I think that's exactly the hypothesis that's been generated, Edgar, but it's yet to be substantiated. And I think this is a complex area, because we know that neuropathic pain can be modulated by cytokines as well. We don't yet fully know whether there's a central effect, that the conventional dogma is that JAK inhibitors don't cross the blood-brain barrier. But on the other hand, we know that in the context of systemic inflammation, the blood-brain barrier might be leaky. And then there are other potential explanations as well. One of the very interesting features that's arisen in the context of the coronavirus pandemic has been that artificial intelligence has highlighted that some of the JAK inhibitors, and certainly baricitinib, has some off-target effects on two enzymes, one called GAG and one called AAK, which have an influence on viral uptake into cells. But there's also a great deal of interest as to whether AAK may have some role in pain signaling, but this also remains speculative. So I think from my perspective, the answer to your question is that the observed data has generated some nice hypotheses, and you've articulated beautifully one of those hypotheses, but we've yet to fully flesh this out. So Vibeke, do you want to add anything to that?
No, but I think it is quite interesting. And I think there is a fair amount of expectation that there must be some central mediation of pain relief with Absolutely. The JAKs. Yeah. So I also think that we have to remember that we've shown you these multiple patient-reported outcomes, and that it's important to look across these different PROs, because they don't really create redundant data, but they measure different domains of response. And I think that's also important because many of our patient-reported outcomes, such as pain and HAC and global, they go down as they improve, which is fine. But then there's no way to actually illustrate that very well, which is what I've really liked about looking at the SF36 domains, because their improvement is positive, and you can do nice comparisons with previous scores and see the improvements. So thus the value of both the patient-reported outcomes and these composite measures, which I think really do improve the validity, reliability, and responsiveness of how we look at patient-reported outcomes, but how we also see how our patients are improving. There's also difficulty in trying to compare across the trials because we have variability in the types and definitions of patient-reported outcomes. We have different ways that patients actually perceive the questions or answer them. And furthermore, we have different patient populations. We tried to show you some differences according to different disease failures, but certainly also if you look at patients who are methotrexate naive, we can see very large improvements that well exceed methotrexate. A good value for these multiple patient-reported outcomes is that they help to define treatment goals. They can make them more clinically meaningful to both the patient and to your perception of them. You've seen that they do correlate with remission or low disease activity. It's very nice to look at both the tempo and the depth of response, as Dr. Taylor has shown you quite clearly, as well as treatment discontinuation rates, which tend to be much better with the JAK inhibitors. It's actually possible to report scores that meet or exceed normative values. And this has also contributed to governmental labeling requirements, which I think are quite important. And you may have noticed that today the US FDA has announced that the JAK inhibitors in the United States will now have a labeling change and be recommended only for use after TNF failure, which I think is unfortunate, but this has of course been based on the concerns about safety. And finally, the generic health-related quality of life instrument, the SF-36, really does reflect the impact across many rheumatic diseases with disease-specific patterns. I showed you the RA patterns, but it's also important to look at disease-specific measures because you're not going to use the SF-36 in clinical practice, nor are you going to use the majority of these PROs. And so disease-specific instruments such as the RAID, the RA impact of disease, is a very nice way to add valuable information that queries across 7 domains of response and impact of disease in RA. Peter?
Yeah, thanks very much, Vibeke. Well, I entirely agree with all these points you've raised. And I think what we've been able to show today is that it's not only important to show that these drugs are highly efficacious and speedy in their onset of efficacy across the traditional composite scores of disease activity, but the experiential issues for the patient and really addressing those issues that matter most to the patient is important. And going back to the study that we did together, those years ago about having a good day. Remember, that was the patient's top goal. I think to have this constellation of improvements across PROs really begins to get at that issue. The final points really I'd like to make, if I may, are that, in recent years, we've seen an enormous emphasis from many highly respected physicians and the community in general that we should all be treating to target. And I would certainly agree that we should be trying to practice treat to target. But there are a few comments about it, really. Firstly, that it's not as widely applied in daily practice as people often pay lip service to. So we all need to make sure we really do measure disease activity the best we can in various ways and titrate treatment accordingly or adapt if need be. But I think there are some flaws in treat to target because it is based on cohort level outcomes. And the first problem is that there are many patients that I think most of us see who will never achieve the desirable targets of low disease activity or remission. We need to think about how best to treat those patients, and it's not necessarily clever to go on trying to escalate immunosuppressive treatment when actually the patients are not exhibiting a response on those composite scores. So that raises questions about non-pharmacological intervention or alternative approaches to management in addition to optimum treatment that suppresses inflammation the most for that individual. Then there's also the issue about what about those patients who do achieve the target but still have subjective issues such as fatigue and pain, and I think this is very difficult. And the traditional thinking of a treat to target approach has been that inflammation comprises a sort of black box, and that if we suppress the inflammation in that black box with any effective treatment, and the assumption from the treatment recommendations both from Europe and America has broadly been that all targeted therapies have similar efficacy in this respect. But is it necessarily the case that they have the same efficacy for some of those generic features of inflammation we're talking about? And my own belief is that the data we've discussed today suggests that might not be the case. It may be that JAK inhibition has a bigger magnitude effect on pain, for example, than is the case for TNF blockade. And of course, there may be numerous other advantages of one drug over another, either way, depending on the needs of the individual and the context. So I completely agree with you, Vibeke, that of course we should be treating to target using composite scores of disease activity. But if we use patient-reported outcomes as well, we can very rapidly see what matters most to the patient. And in some cases, the information in the PRO may actually help inform a management choice and decision. And like you, I really like the RAID. It was, in fact, developed by EULAR as a multi-dimensional tool, but it's ever so easy to do if any of the viewers are not familiar with it. It's just a numerical rating scale across 7 different domains: pain, function, fatigue, sleep, physical well-being, emotional well-being, and coping, and so on. And then there is a weighting to each in a formula that gives you a final score. But a good trick, if you're doing a lot of remote clinics, as I am now, is that if the RAID score is 2 or less, you can be very, very confident that the patient would meet a DAS28 or a CDAI, low disease activity or remission. Whereas if they're above a score of 2, of course, it could be that they need some treatment adjustment. So I think the PROs can be useful for face-to-face consultations, but also in telemedicine. And if any of you have not yet started looking at them and adopting them, I think it's a great idea to become familiar with some of them.
Yes, I agree with you. The rapid 3 can also be done this way. There's a way for converting the scores and then looking at them in the context of low disease activity or remission. And of course, the rapid 3 has become quite popular in the United States. But it is also important to look at fatigue. And it's also important, again, to set a goal for treatment, something a patient wants to achieve that's achievable potentially with an addition or change in therapy. And that is a quick question that really does help to status how the patient is doing at every visit. So we have also been using the rapid 3 online for our virtual visits, oftentimes asking the patient to answer the questions while we're there, or to have them send them to us virtually beforehand. But it's been very useful to ask about that goal of therapy at the same time. And we've been able to also introduce RAID, which is a very helpful instrument. I agree. We have anything more to say?
I don't think from me, Vibeke. Thank you.
I don't think for me either. Thank you. It's been great talking with you. We'd like to tell you your feedback is important to us. Thank you for attending. Hope you've enjoyed this webinar. Please do fill in the short evaluation form. And a repeat of this webinar is now available to view on your YouTube channel, Cytokine Signaling Forum. And please join us for a special edition of Forum Live next week, Thursday, the 9th of September, on COVID-19 vaccination in immunocompromised patients, the OCTAVE study. Register now.